because now you know the patient selection, you know the stimulation. Now she has ovulated also, you have monitored also. Sir has told you about the semen analysis and the semen wash techniques. Now comes the turn of IUI procedure. Okay, so in this procedure presentation, I will be talking about the first and foremost is the consent. That is, this new act has made our life very, very easy. If you go through the act, there is a consent form for IUI, husband semen, for IUI, donor semen, both in English and Hindi. So you don't have to translate. And all Marathi speaking people, they do understand Hindi. So my job is very easy. Just give them those consent forms and take their consent. And consent has to be taken from both husband and wife. It is not like that ki my husband is not here, you do IUI on my signature, I will bring his signature the next day vagara. That is just not allowed. Before the procedure you have to do. Semen processing techniques I will just skip because he has collected in great detail. Now insemination. ये क्यों मर गया? हटा दे. Timing of insemination. Timing of नहीं ना रे, एक वो वाला लिया. Timing is very, very critical. Why? Because if you see the survival of sperm is 3 to 5 days and survival of ovum is 24 hours. So that is why we always time the IUI after 34 to 36 hours of SCG injection. But how you are monitoring? If it is oral ovulation, then every time you don't have to go for ultrasound monitoring. That is not must. Your patient can do self-monitoring of the cycle by doing urinary LH kit. Remember, when you are telling her to do urinary LH kit monitoring, the surge peaks about 12 to 14 hours before the egg is released. A woman can test her urine next day in the morning, and if this test is positive, she can have the IUI next day. So this is how you will be correlating LH monitoring kit when you are planning IUI. Our recommendation is to have intercourse on the day that an ovulation kit turns positive or on the day you are giving SCG trigger injection. And then you can have IUI as it is timed, that is after 34 to 36 hours. But don't tell them to have abstinence for 3 days, 5 days prior to your IUI. The LH surge can be detected in serum 36 hours before ovulation and 24 hours before ovulation. The oocyte can be fertilized, I said, up to 24 hours after ovulation, and sperms are most capable of fertilization up to 48 hours after entering the female genital tract, and therefore IUI is timed based on these relationships. But this is not a very, very rigid relationship. The optimum timing of IUI is still crucial. When it comes to cryopreserved sperm, remember they have a shorter lifespan than fresh sperms, and therefore there you have to do more accurate timing. Cryopreserved sperms like you are using in donor insemination cycles or sometimes in husband insemination cycle also, if they are having distant relationship, if husband is working at some other place, we do take their semen sample and we do cryopreserve so that we can use this sample when it is indicated. So this is again another indication of using cryopreserved semen but of the husband. Double insemination usually does not appear to increase the clinical pregnancy rate, so all the guidelines are saying one IUI is enough. Now pay attention to this slide where there is a recent paper, not recent, but there is a paper and very interesting paper Whether you should do IUI always after the 36 hours of SCG, or you should do it after documented ovulation, or you can do it along with your SCG trigger. That is why I said it is not a very, very rigid timing of insemination. A 2010 systematic review of trials that evaluated the effectiveness of different synchronization methods in natural and stimulated cycles for IUI in subfertile couples concluded that the choice should be based on hospital facilities, your convenience of the patient, your dependence on medical staff, the cost and dropout level, as no method of timing is superior to another method. This is the randomized study of doing simultaneous SCG administration along with the IUI cycle. This is very, very interesting study, because sometimes it does happen in my setup also that patient has come from a far off place and it is just not possible for them to come again after 34 to 36 hours for IUI. So this study gives you confidence that in these cases you can trigger her and you can do IUI on the same day. Because there was two groups where IUI one was done after 34 to 36 hours, and in another group IUI was done simultaneously along with the SCG administration. And the authors, they found no difference in the spontaneous use of SCG injection compared to cycles in which IUI is performed after 34 to 36 hours. Now coming to the insemination procedure, you have taken the consent. Now you have done the timing, and now you have to actually deposit the sperms. As far as position, yes, dorsal lithotomy position, strict aseptic precautions. You should not use any antiseptic solution, whether it is betadine or Savlon. Just clean it with normal saline. Catheters, we are talking, of course you have to do it with minimal trauma, slow injection, and what should be the inseminate volume. So this is your IUI trolley, just contains very, very basic instruments. That is just the speculum, a sterile syringe with blunt cannula, disposable, that is the IUI cannula, and a prepared sperm specimen. Whether you should do cervical mucus aspiration. Now we will be discussing all these procedures one by one, about the role of cervical mucus aspiration, full bladder, whether you should do it under ultrasound guidance, what is the role of passive straightening of cervix, which type of catheter you should shoot, what should be the volume and what should be the speed, and whether you should do 1 or 2 IUI. So this is what we have already discussed. No antiseptic preparation. When the sample is in your own lab, then it has to be maintained at 37 degrees centigrade in a tube warmer. Identity of the sample has to be checked, cross-checked and cross-checked. You just can't afford to have a mixing of the sample. And what sir has said, in case patient is bringing sample from the home, then what I do, that whenever I am taking their consent form, on the back page of that consent form only, we make them write in their own handwriting. My staff doesn't write that whatever sample has been brought by me, that is his name, from home, will be used for IUI for my wife, her name, on this day and time, so that I am safe, that this sample belongs to you, this is yours, and I have used it for your wife. Both signature and signature of one witness from my clinic. Second thing, even if he is giving sample in your clinic, it happens, we have a dedicated semen collection room, which you all should have according to ART Act. You send the husband and wife, but be cautious if he has come up with any male friend, sometimes they just switch over. That male friend gives the sample and it is handed over to your staff with the intention that this is the sample of my husband. So I know I have got CCTVs everywhere, every floor, but you have to be very, very cautious. It is just not that ki husband is giving you sample. So just be cautious. Waiting between loading the syringe and procedure should be avoided. Ideally, it should be carried out in a theater with all aseptic precautions. Cervical mucus aspiration, if it is very thick, we do aspirate, but don't use force or trauma, or just don't go on rubbing the cervix so that you have to take out, all the cervix. Passive straightening of the uterus, most of the times we try to avoid catching hold of the cervix. Only in difficult cases we just apply Alice forceps and we don't lock it, and we just gently pull it so that the uterus becomes straight and it becomes easy to inseminate. Ultrasound guided usually is not necessary, but yes, IUI is a blind procedure. If it is easy, there is no need for ultrasound guidance, but in difficult cases, we do prefer ultrasound guided. But your routine IUI's catheter you can't see on ultrasound. See, I am having IVF lab. I use ET catheter because I have to see the catheter. So whenever we are talking of ultrasound guided, you see to it that you are using an embryo catheter which you can see, and again the cost will just jump because the cost of IUI catheter and the cost of ET catheter is entirely different. Then choosing a right catheter. Market is flooded with so many IUI catheters. We have soft catheters, semi-rigid catheters, rigid catheters. But when we are choosing a catheter, it should be easy to use, it should be non-toxic, it should be semi-rigid, not very soft because it will not go, and it should have a non-traumatic entry. Also, it should provide mechanism to prevent backflow of injected contents. So these are the various catheters you can choose, but ideally it should be a semi-rigid catheter. Now how to go about the procedure. Usually our embryologist gives us preloaded sample that is in a syringe with catheter attached. When you are injecting, you have to inject it very slowly, take 30 seconds of your time. See to it that your catheter does not touch the fundus, because if it touches the fundus, uterine contractions will start. Sperms are injected very slowly. It should take 2 minutes to inject, and the insemination volume is 0.3 to 0.5 cc. Don't have 1 ml, because again you will have uterine contractions. So 0.3 to 0.5 ml. And injecting too briskly again will lead to uterine contractions. So take 2 minutes, even if you are too busy having 100 patient ka OPD, 2 minutes to inject and 30 seconds to come out. Now after doing IUI, we just tell them to lie down for 10 to 15 minutes. That is more than enough. There is no need to give her the hip elevation or leg elevation. But in difficult cases, these are the tips which you should follow. You can have full bladder. That also not too full, not ekdam empty. Semi-full bladder, you can take help of ultrasound. You can use rigid catheters with stellates. I still have a metallic catheter. I don't know whether that metal catheter is still available. I procured it 30 years back. So that metal catheter just goes through and follows the curvature. If you anticipate the difficult IUI based on our history of DNC or whatever, you can do, you can just pass your ultrasound, yes, you can just see the curvature of the uterocervical thing so that it becomes and it gets registered in your mind. So when you are passing your catheter, you know what is the curvature of the cervix and the uterus. Or you can do gentle dilatation on day 2 to day 5. That is in the follicular phase, that is also allowed. And you don't have to use any anesthesia for this dilatation, because the minimum, that is the smallest dilator, you can just pass. And in extreme difficulty, where it is just not going, these are the alternative sites for IUI. Remember, we don't have this luxury when we are doing embryo transfer, because we can't transfer embryos in the cervix. But semen sample, you can have intracervical insemination, or you can deposit this semen sample high in the posterior fornix. That is worst comes to worst scenario, and sperms, they will find their ways. So this is how you should do your difficult IUIs. Role of rest, tell them evidence based that there is no role of bed rest after IUI. We don't recommend, but if she wants to take, it is her wish what she should do. Post procedure care, remember this patient can have abdominal cramps for 2 reasons. Some patients they do complain and they do come to you, pet dukh raha hai. Either we were harsh when we were doing the procedure, or your embryologist has not washed the semen sample properly. That whole cytoplasm was not washed. So that also sometimes gives cramps. So just find out what is the reason behind it. Do tell her some discomfort she might have. Light bleeding or spotting may occur, but she can go to her office and she can do her all the household care. What about intercourse? Don't tell them abstinence after IUI. For donor, if you are doing donor insemination, it doesn't matter. But for husband, we tell them to do intercourse the next day after IUI, and then he can go ahead and do as per their wish. Because if they continue doing intercourse, it increases the chances of your IUI. Complications per se of IUI procedure are nil, except mild discomfort and spotting. But yes, related to your ovulation protocol, she can have OHSS, multiple pregnancy, and I just forgot to tell you in my last presentation when not to give trigger. So when you are using gonadotrophin cycle, if you are seeing 2 to 3 lead follicles, that is 16 to 18 millimeter, don't give trigger. If you don't give trigger here, there is no question of OHSS, there is no question of multiple pregnancy. Document on the case paper that you have told them to abstain from intercourse. Most patients, they do intercourse and they do land up with OHSS and multiple pregnancy. Whether they follow your advice or not is a different thing, but at least document that in lieu of the risk of OHSS and multiple pregnancy, couple has been advised to abstain from intercourse and her cycle has been, yes. Okay? So this is for your own safety. We do single IUI, but for donor sperms, because they cannot do intercourse, it doesn't make any difference. You can think of doing 2 IUI in cases of donor insemination. How many cycles, IUI cycles? I told you, please do only 3 to 4 cycles. Max to max, you can do 6 cycles, but never go beyond 6 cycles of IUI. What happens? She has already undergone 2 to 3 cycles of IUI. She comes to you, you don't trust your colleague, and you tell her that, okay, let me also try 3 to 4 cycles of IUI. She goes to another gynecologist. She also thinks that let me try 2 to 3 cycles of IUI. This goes on and couple lands up with 10, 12, 15, 18 IUI cycles before they come to us for IVF. So do inquire how many cycles she has already undergone.